Rajgopal Shenoy, who is a professor of surgery. He's a multi-talented person, like a surgeon should be, really. He's a singer. I will start, the other end. He's a singer and a chess player. So he has the brains, he has the voice, and he has very popular books. I'm glad to let you know that, Professor Raj, that your books are very popular among our surgical trainees. So it's really a very long CV, full of great achievements. And we are quite happy to have you here to give us a talk on small bowel obstruction. So the floor is yours, sir.
Thank you. Can I share my screen?
Yes.
Can you see the screen?
Yes.
Thank you. At the outset, I would like to thank Dr. Abbas, person who has contacted me for this talk in Sudan. So thank you very much for inviting me to this evening. I am glad to be amongst you. Whatever possible from my side, I will try to share my experience. And with this background, can I start now?
Yes, please.
So, dear friends, 15th was our Independence Day in India. Just few days back, that was the time I got this correspondence was going on about my confirmation. I'll bring greetings to you from India. And typically we say like this, Namaste. That is what you would have seen our Prime Minister showing like that. So this is how we greet all of you. And this is the, yes, thank you.
No.
This is the university from which I come from. This is called as Manipal Academy of Higher Education. And this, our college is more than started in 1953. So I joined this institution in 1986 after my graduation, that is the post-graduation. So I bring greetings from my place, Manipal. It is in the southern part of India. With this small background, thanking you again for giving me this opportunity. I thought we'll start with some emergency scenarios for the talk first. More common, a problem of intestinal obstruction, which is day-to-day happening. Everybody, whether it is a junior resident or a senior or a professor, would have come across all these cases in casualty. With all the, in spite of having so much knowledge, sometimes, we do go wrong there because that's why abdomen is called as Pandora's box. We do lots of investigation, no doubt, at the end land with the exploratory laparoscopy. Today, what I'm not going to talk is on this side, that's that colonic, neonatal, etc. And if the time permits, etc., maybe next sometimes I will talk about large bowel. But today I will concentrate mainly on this. Again, every possible scenario may not be possible to discuss in this whatever time given. This is what are the basic things in which I discuss, and there are some interesting case capsules at the end, and that's how we can proceed with the today's session. So every disease has got some definition. When you contents of the intestine cannot travel distally, you call it as intestinal obstruction, right? Yes. So whenever a casualty, when a patient comes, when you discuss whether it's an ileum, means I'm talking about small bowel today. This is what is the more common list one should know. Is it an obstructed hernia? Are there adhesions? Is there a stricture? Or is it intersusception? Or is it a tuberculosis? Or any congenital bands, etc. Other part of that is more dangerous or serious is a gangrene. It happens, when the vascularity is affected. So volvulus twisting, obstructed hernia, intersusception, these are the few cases. Colonic obstruction, these are the list. And today I will not be discussing this list. So now you can see here, pathophysiology. We will be talking mainly dynamic, means there is some obstruction, the intestine is contracting against the obstruction. Adynamic is obviously paralytic. Now there are various causes, you can classify whichever way you want, but in the lumen means inside, these are the few things. In the developing countries, including ours, you do find this in children, especially ascariasis, and of course in a neonate. So in the wall, tuberculosis is still a common disease in India. I was also told that it's common in Sudan also. Crohn's, not all that common, but still we see. And these are some of the various causes, which is very easy. Anybody can make out, right? When it is become more severe, you call it as an acute. Acute means something which requires an urgent admission and resuscitation. Sometimes you get a chronic because of malignancies. It's more common in large bowel. And there is a stricture, let us say, slowly patient is developing features of obstruction that we use the word subacute. And one fine day, suddenly it can go for acute. So this is how we classify. Now, depends upon the nature, it can be a simple, where the blood supply is not seriously impaired. But it can be a strangulated. When you say strangulated, means obviously blood supply is seriously impaired. And when there's a closed loop, means both ends of the intestine are blocked. We'll have a picture later. So these are some of the common causes, I think, which is not difficult. So what really happens when there's an obstruction is that there is hyperperistalsis, no doubt proximally, and then there is a dilatation. Normally, without our knowledge, we swallow saliva. There is some gastric juice, intestinal juice, pancreatic juice, all that will accumulate. But there is no absorption now because it's dilatation. So that itself causes the dilatation. And after some time, what happens? Distally, the bowel becomes contracted and there's no peristalsis. Slowly, it becomes totally paralyzed and flaccid. So what is the cause of this distension? One of the important features of intestinal obstruction is distension. So this is the swallowed air and some diffusion of the air, and there is stasis. So bacterial activity is there. So that causes distension. I was telling you about what normally is secreted in the body. Look at that. So even if you keep the patient fasting, you would have already got this much fluid inside. So you can imagine this is not absorbed. This is the loss. These are all the fluid loss which is going to have almost, you can see, so many liters. So that is why they easily go for hypovolemic shock. They may not have vomiting, even then they go for a shock because of this reason. Now that obstruction continues, when you say lack of blood supply, now that's called as strangulation, right? So you can see here the problems which happens in a strangulation, capillary rupture, hemorrhage. Slowly bacterial proliferation takes place. Endotoxins are released. Once these endotoxins are released, even without a perforation, there is migration of the bacteria. That is what is meant by the word transmigration of the bacteria happens into the bloodstream and to the peritoneal cavity. All may result in ultimately a gram-negative shock. So these are basically lipopolysaccharide in nature. These are the one which bring gram-negative shock, also called as septic shock, and later it gives rise to multi-organ failure and obviously untreated cases, death happens. If there's early gangrene without obstruction means always think of mesenteric thrombosis or embolism, one of the dangerous and fatal condition. So loss of blood volume also happens because obviously whenever there is a gangrenous segment, what happens in a necrotizing enterocolitis or a gangrene due to whatever be the cause, significant blood is lost. Often it is passed through the rectum as foul odored blood. So a quick recall for all of us. Start with obstruction, distension, venous compression. You can see here slowly arterial compromise, and if there's a band, interception, volvulus, gangrene, proliferation of bacteria, and ultimately septic shock. So this is what happens in a intestinal obstruction. So what we are trying to tell in the pathophysiology is three important issues. One is the significant fluid loss. So that has to be compensated obviously by giving IV fluids, etc. Second important is the gangrene means significant blood loss plus sepsis. So a important gram negative, gram positive anaerobic cover, and we have to have the distension of this patient to be treated. Otherwise, he will have difficulty in breathing also. He may aspirate. So this is how we should think in case of obstruction, and these are the pathophysiological points. Right. Now we will go on to the clinical features. I think all of you know that pain abdomen is the most important thing, which is colicky abdominal, which comes and goes. Frequency depends upon the type of obstruction. But remember, it's a severe colic. Significant pain is there. Patient bends almost, and he also vomits, and initially food content, then bile. Then we use the word one, feculent. When we say feculent means it is actually vomiting of the feculent contents, means it is from the ileum. It is not fecal matter. It's ileal contents. So that indicates a hemorrhage, as well as so ileal contents which have undergone stasis for a long time. That's why they have the fecal smell. If the patient vomits altered blood means there is a gangrene and a hemorrhage. Two things to be noted very carefully when patient is vomited, get these details. So you can see here nasogastric tube, also called a Ryle's tube, has been put. Look at that color. This is the color of the typical feculent, vomiting, bit thick in color. So you have next is the distension. Obviously, I mentioned earlier fluid as well as the gas, which is responsible for the distension, and constipation, because distal bowel is not acting. This is what we call as a cardinal 4: pain abdomen, vomiting, distension, constipation. And obstipation means failure to pass the feces and flatus. That's the one example of, I mentioned earlier, what has been called as closed loop obstruction. This is the hepatic flexure area, one growth is there. And this is the ileocecal valve, which is competent. So this becomes a closed loop. So obviously cecum becomes big, dilated, and it may rupture. So this is the closed loop obstruction. You can have an obstruction, but patient says, no, I'm still passing some amount of fecal matter, flatus, etc. This happens sometimes when you have a fecal impaction. Riches hernia means a small portion, circumference of the hernia, intestine, which is obstructed. This happens in a femoral hernia. Even a Meckel's diverticulum can give rise to this picture. That's what is second is the Riches hernia. A gallstone can cause an obstruction. Can also, these patients can have diarrhea. Mesenteric vascular occlusion. Actually, there is no real inside the lumen or mechanical obstruction. It is basically a gangrene, so they can still have a diarrhea. These are 4 exceptions to constipation. So what is that you are going to look now? You are going to examine the patient. You examine in this way. First look for the dehydration, which is the usual. Any patient comes to the Emergency department, you look for evidence of dehydration, no? Sunken eyes, drawn in cheeks, all this. Look at the abdomen. There's a tummy is distended there, and tympanic node. You may be lucky to get this step ladder peristalsis. Also, this happens in a left-sided colonic obstruction, not common. And always don't forget to examine the renal orifices. Just see whether you can see this. You can see a step ladder peristalsis like thing. Abdomen for some time. See the intestinal loops getting prominent. Can you see this? So this patient has been operated. I'll tell you about this patient later. He was operated for a tuberculous stricture in the ileum, and it was resected. But you can see that incision there, and I came back with features of obstruction because there was a problem at the cecum also. So that means that is important when you diagnose one reason, one cause for obstruction, there can be another. So this was a missed second one, right? Then what about the gangrene? So you are looked for the evidence of dehydration here. Then you are looked for the abdomen. Okay, you may get a peristalsis. And if the patient has got sepsis, oliguria, rebound tenderness, extreme tenderness, you suspect always a gangrene. And if there's none of these are there, but obstructed hernia, another example, tense, tender, irreducible hernia. So you always consider whether the patient is having obstructed hernia. There's an entity called as a Madel's hernia, where there can be a loop within the intestine. Outside there may be a hernia without having any tenderness, but one should be careful not to miss this condition called as Madel's hernia. So that's just to give an example of a obstructed hernia. If you get this type of case of internal obstruction, it's very obvious. A massive obstructed abdominal wall hernia, also called as ventral hernia, but there's incision, so it's an incisional hernia. This is obstructed umbilical hernia. So examine the patient from top to bottom, full, so that you will not miss any hernial sites or any other pathology whenever you have got a case. So I already mentioned to you about closed loop obstruction. What really happens when you have got a two ends are blocked like sigmoid volvulus. I mentioned about carcinoma, right colon, etc. You always auscultate, inspection, palpation, percussion, tympanic, auscultate. You may find the bowel sounds are more what has been mentioned as loud noisy sounds, also called as borborygmy. So that is how you complete the clinical examination. And I mentioned to you, don't forget obstructed hernia, and don't forget to do the rectal examination, because it is important that you may find a carcinoma of the rectum. You may totally miss. So it should be important that not only you put a finger inside, find out the tone of the sphincter, any growth you have felt, take it out and see any blood is there. You may get a foul odor. It could be intestinal gangrene. If there's a rectovesical pouch is having some metastasis, yes, those metastasis, large metastasis means patient may be having inside the perineal cavity also. One loop would have gone and stuck. So what I'm trying to tell is search. Don't forget a vaginal examination. It may give some diagnosis. Sometimes the female pelvic pathology, ovarian or uterine or whatever is may be responsible. So complete examination should include rectal, vaginal examination, and of course we will also examine the supraclavicular node. So I have completed now common causes of small obstruction, basic principles, and clinical examination, how to make a diagnosis of a small intestinal obstruction in the form of tympanic node, central abdominal distension, that bile vomiting or the bile or feculent vomiting, and step bladder peristalsis. And we also know, examine itself if there are adhesions, if there's a scar or hernias, all that you should do. So what are the investigations you do? These are the few common investigations. If you have a total count increase, means you suspect he may be having a infection, means maybe a gangrene. Most of these patients have been vomiting. They are significantly low sodium, potassium, chloride. So you have to replace them and do arterial blood gas analysis in these patients, because especially if there's a gangrene, the pH is very low and there is metabolic acidosis. So you may have to, not you may have to, you should correct it. So we'll see it a little later. Yes, you take a plain X-ray abdomen. If you see some concentric, see, you can see here, regularly placed, this is a jejunal loop. And if you see a larger loops, incomplete, this is called as hostrations. This you get in a colon. And cecum is usually round and ileum has got no characters. So this is how you diagnose in a plain X-ray. So what are the advantages of the plain X-ray? If you see a multiple gas fluid levels, so it could be a small intestine obstruction. We sometimes take a supine, it indicates the distal level. And usually in the normal, if you take an X-ray, you'll find two maybe normal, one at the duodenal cap, another at the ileocecal junction. But here you may find more loops. You can see a 2 to 4 in jejunum. Ileum means more. So all these details you can make out in a simple plain X-ray. Of course, sigmoid volvulus, large one, we call as a inner bend sign or a tire sign also. So this is the omega sign. So lots of information plain X-ray can give rise to. So just look at this picture. I said about 2 or 3 in jejunum, 4 and 6 in ileum. So this one picture will tell you this is terminal ileal obstruction. You can see multiple gas fluid levels, right? Very classical of a terminal ileal obstruction. Same patient, we took this is a different patient, sorry. When you make the patient lie down, you can see the gas is almost down there. So that's the one advantage of supine, means you know roughly the distal limit. I'm not sure whether you can make out, carefully watch. These are dilated jejunal loops. This is what I meant by volvulae conniventis. And we can see this whitish structure like thing here. This indicates edema. So this is how you make a diagnosis of a plain X-ray abdomen showing intestinal obstruction. Will you do ultrasound? Common question that is asked. Ultrasound is today called as extension of surgeon's arm, means you should do, because it's very easy and you can see, at least you will give a clue, especially patient maybe you may pick up a gallstones there, it's a gallstone ileus. A good sonologist can make out even an intersusception. And if you add the ultrasound with the Doppler, you can even check the vascularity. We'll show that later. So that means ultrasound is extremely useful because it's very easy, non-invasive. Only thing is it's operator dependent, the one who does. So that is the main problem. Otherwise, it has got more benefits. In all patients, if there's a possibility, please do a CT scan, even if you define an obstruction. But remember, contrast you are giving, so you should be careful not to produce a contrast-induced renal failure. You can see here, it's called as a oral sign-like thing. You can see round here, and that is a very classical of a intersusception, right? And here you can see dilated intestinal loops, thickened, prominent. Can you see this? So this is how you make a CT scan can give a lot of diagnosis. Even in obstruction, yes, its a sensitivity may be low, but it increases if there is total obstruction. So CT scan is a extremely useful investigation. you can see that called as CT skiagram. You can see it's a case of a hugely dilated ascending colon and sigmoid here. Can you see here intersusception? Another CECT is showing the intersusception. So these are few images. So that means now, up to now, we were able to do the investigations in a case of small intestinal obstruction. I repeat, what we have done is blood examination, specific look for total count. It increase means we suspect could be a gangrene. You also do the other tests. You also should do the cardiac evaluation. Patient may be having a mesenteric vascular occlusion. Echocardiogram is required. Ultrasound next you do abdomen. Look into the various, I mentioned about the uses of that, and CCT you are done, and you have come to resuscitation of the patient in the casualty. The most important success of any emergency for that matter is a golden hour. What we call as within 5 to 6 hours, this patient requires some kind of a definitive treatment. But this is a time you need to resuscitate this patient, because more delay, definitely it causes hypotension, permanent shock, renal damage, renal failure, and all those complications. So third space loss is one of the important features. So that is what you should see here. Now, quickly, I'll get the details, but just remember the basic principle of any acute abdomen resuscitation. These are A, B, C, D, E, F is what I have called it. It's there in my books also. All of you know that you will put a nasogastric tube so that you relieve that distension and all. You take care of the bowel, that don't give anything by mouth. You should not stimulate the intestine, it causes perforation. Put those basic charts. You ask for temperature, pulse, respiration, etc. We all know that organisms play a very important role. So you need to cover gram positive, gram negative anaerobes. And you give fluids and do, lastly, I mentioned to you exploratory laparotomy. So these A, B, C, D, E, F, which all forms the basic principles of any acute abdomen. So this you should know. So now what is that resuscitation you are aiming at? When a patient is in the emergency department, if patient is critically ill, I use the word critically ill. Imagine the pH is 7.1, patient has got severe tachypnea and tachycardia 140, 150. So obviously requires the basic ABC, that is not nasogastric tube, that is for resuscitation of ABCD for acute abdomen. Here these patients require an airway breathing. He requires oxygen, and for some reason you are not happy, saturation is very low, you may have to do a mechanical ventilation. That is what are in a sick patient, very critically ill patient. Then comes your resuscitation of circulation, right? This is what is the basic ABC of the any critically ill patient. We are concerned, we need to concentrate on these two phases. What is the first phase? I mentioned to you, there is significant third space loss. So we need to give adequate fluids in such a way, the vitals have to come back to safe level within 6 hours. Can't go on telling that by 2 days, no. When I say vitals, obviously pulse rate, blood pressure, mean arterial pressure, etc. This is what you should get. Now, at least the systolic should come to 90. Now, what about the phase 2? Phase 2 is that you give the fluid. Basically, aim is to eliminate metabolic acidosis within 24 hours. But now what is happening between 6 and 24 is the surgery. So what I'm trying to tell is, just because patient has got acidosis, there is no point in giving soda bicarbonate. Your aim is to eliminate the septic focus within this period. So that is why I mentioned to you, phase 1 is for the fluid, very early. Second part is this, you have got 24 hours, in between is the surgery. I hope this message to be taken, right? So then how do you correct the fluid? I mentioned to you within 6 hours, you may have to give boluses. Now it is not like 100 ml, 150, 200, you can really push. Even 250 ml boluses you can give so that he passes adequate urine output. Of course, these patients will have a catheter, and later you can do a maintenance of 100 to 150 ml per hour so that to maintain adequate urine output. So I think fluid part is clear. What is the agent we use? Is a ringer lactate. Any alternative? Yes, this is the best solution. You may have to give a DNS, that is the dextrose normal saline also. We already started antibiotics for all the 3 gram-positive, gram-anaerobes, cephalosporins, gram-negative organisms. You can give gentamicin or even amikacin, and you have got other is the metronidazole for anaerobes. And this is how you prepare these patients and for surgery. Now, what is that you have decided this patient that I am going to do surgery? These are the few common questions you ask to yourself. What is the probable cause of obstruction you think now? Is it a small bowel obstruction? Is it a large bowel obstruction? Is it a simple obstruction? Is it a strangulation, or is it a surprise? So before you start your case, keep this thing in your checklist, and that's how you should start thinking. Now we'll go one by one. So what is the probable cause I mentioned? You will see a laparotomy scar means, oh, it is mostly adhesion. Each one of them will be a little later. If the hernia is there, very obvious, femoral, don't miss femoral in a female. If the elderly man, smoker, atherosclerotic, most probably mesenteric ischemia. Elderly people with the constipation can have carcinoma rectum. What about younger patient? You may have to consider congenital causes, like including malrotation. You see a deformed umbilicus. Oh, it could be a vitalointestinal duct anomaly, like a Meckel's band. All these to be kept in mind. In a women, of course, many of the women would have undergone cesarean section or maybe hysterectomy, pelvic surgery. Think of adhesions there, bands, and don't forget gallstone ileus. So this is all the things which you should keep it in mind. So what is the cause of obstruction? What is the second question we asked? Is it a small bowel obstruction? If the cecum is collapsed, means it is small bowel obstruction. If the cecum is distended, means it is large bowel obstruction. This was the case of a terminal ileal obstruction. Now, is it a simple obstruction? Yes, when there's no gangrene. You have a doubt, pack the bowel with the warm and moist packs, give oxygen, pure 100% oxygen, tell the anesthetist, and look for these 4 P's. Peristalsis, peritoneal sheen, that's the color. Pulsations, pink color. If all these are present, means bowel is healthy. Is it a large bowel obstruction? Today I will not talk about this. If the cecum is distended, it is large bowel obstruction. Is it a strangulation? What do you mean by strangulation? Can you see here? Areas of gangrene. So that's a gangrene. Foul peritoneal fluid, blood. So that means that has to be resected. So these are the 5 important questions you ask yourself and go to the laparotomy. Last but not the least, surprise. Suddenly you open, you don't know what, sometimes difficult situations. There may be an ileus sigmoid knotting. There could be an internal herniation. All these are possible. Don't hesitate to take the help of a senior experienced surgeon, right? So these are the various steps we take. And last but not the least, before we take individual cases, we proceed with the exploratory laparotomy. And what do you do there? These are the principles. Every resident, Everyone should know. Try to give always a midline incision, and bowel is distended. Don't create enterotomy. Little be careful when you open the peritoneum. You get some suddenly air, means there is perforation. You'll find some bile, pus, bile, or fecal matter. So send it for culture sensitivity. Handle the bowel carefully. Trace up to the DJ flexure, small bowel, and trace up to the ileocecal junction. I mentioned cecum is distended, means it could be large bowel. If the cecum is collapsed, means it is small bowel. And check for the vascularity. I mentioned how to do it. Try to feel the lumen inside. You may find gallstones in the terminal ileum, some kind of an obstruction, food bolus, foreign body, anything is possible. Lucky sometimes as soon as you open, you'll find a small interception with the Meckel's. Oh, you are lucky. Treat the cause. I mentioned when in doubt, always call for help. What do you do at laparotomy? You find a gangrene, means you resect. If there are adhesions, means you release. If you have got a band, means you divide. You have got a gallstones, means remove. Volvulus means untwist. So these are various things which you do. But these also are important problems. What is this damage control surgery? Very sick patients, multiple perforations, whether it's due to tuberculosis advanced. Oh, minimum thing you should do. Minimum thing. Extensive gangrene. You do a resection, but don't do anastomosis. That's what I mean by damage control. Just exteriorize the bowel. Bring it outside. Let the patient improve. After that, go in. You may also face a second problem here. Closure of the abdomen. You will have a problem in closure because abdomen may be tense. Relax. Don't close the abdomen. Just close the skin. Different types of treatment is available for that. Laparostomy, it's called as. Today we'll not discuss, but just remember these are the principles what you do, right? So with this, there are some few images. Can you see this? Distension of the bowel. That is what is causing hypovolemia and shock. Look at this tuberculous stricture. Can you see the tubercles on the surface? There was a small perforation also here. We have to resect this, and you can imagine such a dilated loop to anastomose. You know that we give what's called a cheatle cut. With difficulty means you do a bypass. Look at that massive gangrene, extensive gangrene. The bowel has become almost like a thin papery. A band which was causing obstruction. A hugely dilated sigmoid. Extensive tuberculosis with the perforation with the stricture. And what we did in this patient is exteriorization. We resected, and one loop we brought it outside. Can you see the other loop here, distal? That's ileum there. So these are some of the common surgery which we do in this type of patients who have got various obstruction, right? So with this background now, I have given only the principles. I will discuss some common cases of, in little more details, of a differential diagnosis of intestinal obstruction. All of us have got experience of treating most common condition, obstructed hernia. When they come, at least make one attempt to reduce it by elevation of the leg. Try to do a gentle, ask him to relax and what has been called a taxis. But if there's any gangrene, please don't do it. Straight away take the patient for surgery. Extremely toxic patient, very tender scrotum, means it's probably a gangrene there. At surgery, don't divide the constricting ring, that is the deep ring. First you aspirate. Only after aspiration you divide. Otherwise this toxic fluid will go inside. Otherwise usual repair, but avoid the mesh. Because it's a obstructed hernia, there is a gangrene. Even a tissue repair is fine, and let us see later if he comes with the recurrence. That's about obstructed hernia. All of us have got experience with the Meckel's and with the band. You know, it's a VI duct anomaly. So it usually can produce the massive bleeding. Diverticulitis is common, but with the band, it can cause obstruction. It can give rise to intussusception, or it's also called a hernia of the litter, a hernia containing Meckel's. How do you suspect Meckel's? One of my professors, looking at a 12-year boy, he gave a diagnosis. You know how? It was a 12-year child. He saw the umbilicus and he said, there's something wrong with this umbilicus. He has not undergone any surgery. That means adhesions are not there. Up to now, he was okay. And mother said once or twice, child passed blood. And he gave a diagnosis of a Meckel's diverticulum, and it was perfect. Even ultrasound and CT scan did not pick up a Meckel's diverticulum. That's what I'm trying to tell you, the clinical importance. So that's how it is. There's the Meckel's with the gangrene. You know, that's a band there. You always resect and anastomose, because you know most of the time what happens, you look at here, the lining is usually the gastric tissue. That's how the bleeding occurs. That will line also the small intestine adjacent portion. So you don't remove only the Meckel, remove this adjacent portion, right? So what do you do? Investigation, very difficult. You can't pick up this with the CT scan and ultrasound. If there's active bleeding at least 0.5 ml per minute, then only this technetium scan, what's called as per technete RBC tagged scan, will be able to make a diagnosis. Otherwise, it is difficult. So when in doubt, we always open and do the Meckel's diverticulectomy. One question maybe somebody may ask, you are open for something and you find a Meckel, should I remove? This is what has been called as incidentally found Meckels. So now there is some recommendations here. There are some scoring systems you can refer in the internet, it's available. But children under 2 years of age means there is more chance of a diverticulitis and perforation. With the band, with the adhesion, with the narrow base, so long, all these are usually indications for what has been called as incidentally found removal of the Meckel's diverticulum, right? Yes. All over the world, one important cause of intestinal obstruction, small bowel, is adhesions. Whether the pelvic surgery done for appendicular rupture, peritonitis, or I said about the pelvic surgery, I mentioned about hysterectomy, etc. But try to do always a conservative line of management, because the gangrene is not all that common. You can give one up to 2 days, 3 days, even little extension, provided there is no peritonitis. But of course, if the patient comes late, you may have to do a laparotomy and release them. There are so many causes here. Many patients are receiving radiation, whether it is due to carcinoma cervix or even a rectum for that matter. Sometimes they come with a small bowel obstruction. Radiation strictures, all those 5 I's you can see: infection, iatrogenic, ischemia, injury, irradiation, right? So there's a triad which has been described, how to make a diagnosis of adhesions. So pain, tenderness, and change in the pain on change of the posture. India, we still do see tuberculous adhesions. You can see here, this was a case of tuberculosis. And so investigations, as I mentioned to you, you can do a CT scan. And as I mentioned to you, adhesion is the one patient where you can always try to do conservative, because if you do surgery, again you cause adhesions. So try conservative, but if this does not work, obviously, if the patient has got not significant distension, you are expert, try laparoscopy. Few adhesions in the pelvis, you will be successful. Otherwise, you may have to open. And very nice statement given by Harold Ellis here. It's better to leave the abdominal wall on the intestinal surface than leave the intestinal wall on the abdominal surface. What it means, when you are trying to release the adhesion, don't go too much close to the intestine and cause a hole there. As well, you leave the portion of the abdominal wall on the intestine, nothing will happen. That's what it means. Can you prevent the adhesions? We'll come to that, but at surgery, you have the facilities for what has been called as expanded PTFE with a membrane composed of hyaluronic acid and carboxymethyl cellulase they have used. Other better than that is what has been called a bioresorbable membranes. I have not used this. So these are the ones which have been mentioned because of this. They do not cause much adhesions, supposed to be safe. If a question is asked, can we prevent adhesion? Answer is no. Very fact that you do a laparotomy for whatever condition, it causes adhesions. White skin is definitely more vulnerable compared to dark skin. Here also it's important. You see this. All these things you should take care at surgery. Bowel should be handled very carefully. There should good suturing. There should not be any tension. The worst two causes for adhesions and are tension and vascularity. Both can also cause anastomotic leak and again give rise to adhesions. So these are some of the things which you do a good surgical technique, very good handling, clean dissections, avoiding anastomotic leak. In a long way, it will go in preventing the adhesions. Good peritoneal wash in case of obstruction. What are the other causes you may find as a obstruction? Bands. These are not difficult. The various bands have been mentioned, and this is how it is. You divide the band and do a resection anastomosis. Look at these pictures, all my personal collections. This is an adhesive band here, a congenital band, sorry. Look at the adhesive band, one band which has caused, look at the gangrene there. This I have shown you earlier, omentum. These are the tuberculous loops. This tubercles itself will give a diagnosis. This could be tuberculosis. One other condition which we all know that cause obstruction is a gallstone ileus. This is how we make a diagnosis. Whenever you suspect a lady having a gallstones, come with intestinal obstruction, gallstone reaches the ileum through cholecystoduodenal fistula, right? And cause problem here. So because of this, there is pneumobilia, very important point. When you take an X-ray, you find pneumobilia, and then you find a gallstone in the terminal ileum. This has been called as aberrant gallstone, and patient has got intestinal obstruction. You suspect this could be a case of a gallstone ileus, right? So treatment for gallstone ileus, single stone, just make a small enterotomy and take it out. Gallstone reaches the terminal ileum is the narrowest area. This was our patient with one stone coming out, and behind which there are 16 stones came out here. This was a patient. The question is that sometime which is asked is, will you do cholecystectomy same setting? Patient has got significant hemodynamic instability. In a case of gallstone ileus, better not remove gallbladder because you have to treat the obstruction first. If patient is stable, you can always, if the gallbladder is easy, because sometimes it is difficult, there can be cholecystoduodenal fistula is there. You may have to repair the duodenum also. So because of that, it is not advisable. When in doubt, don't do it. You can always do in the second stage. The other important cause is an intersusception, which you know the classification, simple, compound, retrograde. But I am now talking to you about adult intersusception, because pediatric or a child, it's usually these are the causes mentioned. Usually it happens in the weaning period, you know, that 6 months, 9 months time. So whereas whenever an adult patient comes with intestinal obstruction, you always consider there are some causes. So these are the important causes of adult intersusception, right? So including Meckel's, polyps, etc., etc. So always remember, whenever you handle a second intersusception, there is some cause. This was a case of a large polyp there. This is a pedunculated polyp. This was a carcinoid tumor. This patient had Meckel's diverticulum inside. All these are adult intussusception. They all require surgery because the pathophysiology can be quite bad. It can go for a gangrene. So, but in pediatric age group, you find it usually first male born infant, and this called as a red currant jelly is the one which is diagnostic, and this is a sign which has been described as what has been called as sine di dance. Empty right iliac fossa. This was that contracting mass, and mother is asked to feed the baby, and you put your palm, examination in the umbilical region, you may pick up this. Today, if you have a, as I mentioned earlier, ultrasound along with the Doppler, even you can say vascularity, and this sign which has been described as donut sign, also called as pseudo kidney sign. So pediatric cases, you do hydrostatic reduction by putting a lubricated catheter and introducing saline, whereas in all adults I mentioned to you, they require a resection because there is precipitating factor, right? So that's what we have done here. One other question sometime you may be asked, should we do appendicectomy in patients? Suppose you have reduced the intussusception in a child. Yes, you should do. Otherwise it causes confusion. Should you fix the cecum? No, because ileocolic intussusception does not recur. Should you suture the terminal ileum to the side of the ascending colon? Some people do it. No harm in doing it. It's not required unless there is so much mobile cecum and ascending colon. So these are the few points about the intussusception. Today I will not talk much about ileocecal tuberculosis. Maybe once I take intestinal tuberculosis I will mention. But to quickly to tell you, India we get significant number of tuberculosis patient. This is the ulcerative variety which causes stricture in the terminal ileum, and hyperplastic variety is the one which causes a mass in the right iliac fossa with the cecum which is thickened there. So, and that is what you see here. This was a mass, is nothing but the hyperplastic variety. It's a chronic granulomatous mass, whereas the stricture is the one which you can see here, causing massive proximal dilatation with these tubercles. So this is how they can present with the acute obstruction. Just do an X-ray abdomen, do a laparotomy, resection is the treatment. But if you have a time, this is the area subacute obstruction. Always you do the test, try to get a biopsy. And today important thing is not only to prove the diagnosis of tuberculosis, but also to do what is called a CBNAT. That's a cartilage-based nucleic acid amplification test, so as to know the rifampicin resistance, right? So this more details of tuberculosis we can discuss some other time, but quickly, if there's one stricture, you straight away to the resection anastomosis or stricturoplasty. Look at here, so difficult. So we need just a bypass here. This is the limited colectomy. That's what you do in tuberculosis. Last case you can see here, perforation with the peritonitis, and in such patients, I mentioned to you one slide earlier, resection, anastomosis, bad patient, shock, they may not tolerate the anastomosis and a longer procedure. Just bring the loops out, what has been called as exteriorization. So that's about the tuberculosis causing stricture. For a completion of the strictures, Crohn's disease is another diagnosis which produces stricture in the terminal ileum. You can see this was our patient, creeping fat here. You can see the transmural inflammation, and that was the stricture, and this is a non-caseation. So Crohn's disease, tuberculous stricture, radiation stricture, ischemic stricture. These are the four strictures one should consider when you find terminal ileum is obstructed as the differential diagnosis. Rarely, if a patient had an obstructed hernia, you have reduced it successfully, this patient may come after some time with that ileum which was obstructed there. Small area can undergo stricture. These have been called as Gary's stricture. So these are the strictures in the terminal ileum. And for double balloon enteroscopy is the one which you pass from the mouth, and to reach that area, you can take a biopsy and you can even dilate and treat accordingly. So this is one facility. If you have got a good gastroenterologist, he may be able to do it. This is the last condition which I am discussing. After that, I have got 2 or 3 case capsules. So this one condition is can be discussed also for 1.5 hours. But all of you should know, elderly patient, smoker, both artery as well as vein can give rise to problem. So that is called as mesenteric vascular occlusion. You can also get without occlusion. This happens in ICU when the patient with the myocardial infarction, hypotension, etc. You know the famous picture. Blood supply is very narrow somewhere here. And if you imagine a superior mesenteric artery is thrombosed here, it's an end artery. The entire colon up to 1/3 here and entire small intestine. So entire small intestine and 1/3 of the transverse colon up to here will go for a gangrene. It's fatal. This is left-sided ischemia. It's called a ischemic colitis. So various causes are there. You can see here. So my slides will be with you. You can always copy this. Are the various causes of mesenteric vascular thrombosis. Basic problem in all patients are vascular congestion, capillary integrity is lost, inflammatory cells accumulate, mucosal ulcers, translocation and transmigration, endotoxemia, and ultimate result is, I mentioned to you, it's an end artery, the whole small bowel and the colon becomes gangrenous. But what is important here is, every event is suddenly. This condition is something which is so sudden. Sudden event, sudden bleeding, sudden collapse, severe abdominal pain. And you palpate the abdomen, you may find not much findings, but tenderness is present. So this is how you make a diagnosis of a mesenteric vascular occlusion, right? You do the usual investigation, but most important is to rule out any gangrene. That's called as, you want to do a D-dimer. That's elevated in this also, nothing but basically it's a fibrin degradation product. It will be elevated, right? And the serum phosphate levels are also elevated. Do an emergency angiogram. You look at this patient. This was treated as an obstruction, but very carefully you watch. There is air not inside, it is in the wall of the intestine. This big air is inside. I am not talking about that, but I am talking in the wall. So he was treated as intestinal obstruction of adhesion because this patient has undergone surgery for some laparotomy for peritonitis sometimes. After 3 days, he did not improve. Look at this picture, lot of air. Then the CT was asked. You can see this is the air inside the portal vein, and this is air in the bowel wall, pneumatosis, colon here. So this is mesenteric vascular occlusion. That's how our patients will have the posture. And you can see this was the patient whom I referred. He was treated outside and later he came to us. This is the gangrene which is fatal, and this is another patient, and this is small portion, lucky. Few of them will be like this. So what I am trying to tell here is, the only way you can diagnose this is a selective catheterization, intra-arterial papaverine infusion. If no in response, even you may have to clamp it and do what has been called as embolectomy. You can see here superior mesenteric artery should be opened. You can put a Fogarty catheter. You can extract the emboli, and if necessary, go in again and do a relook surgery. So this is superior mesenteric vascular occlusion. That's what I mentioned about the papaverine infusion, right? So other rare causes of obstruction, we call them as internal hernia. There are some congenital defects. This is also herniation can happen. Also today in obesity surgery, Roux-en-Y bypass also it can happen. It's called Peterson's hernia. So these are some of the various causes of internal hernia. Gastrojejunectomy used to be done earlier common. So a transverse mesocolon, if you are not sutured properly, that is the internal hernia. So these are some of the areas where you can get, it's also called a Stammer's hernia. So one loop can go inside and cause obstruction. So that has to be treated. One rare entity, we don't come across much patients. I got only 4 or 5 patients in last 30 years of ileosigmoid knotting. This is called as a compound volvulus. So here both ends of the ileum and sigmoid both have been obstructed. See here ileum twists and resulting in a gangrene of the ileum and sigmoid, or both, a difficult problem. That's what I mentioned. In that type of situation, you may have to call for help, right? So, sir, I have got 3 or 4 cases, what are called as case capsules. If I have the time of 10 minutes, I will present that. Is it okay?
Yes, sure. Please do.
Thank you. See here, remember this patient, I have shown you that video. He came with the lower abdominal pain and vomiting, and a surgeon operated. There was a stricture, he resected. He, 8th day he was discharged, because that time he was taking very little fluid, but he slowly came with obstruction. I brought this here only to bring our attention that especially for a junior people, when you open the abdomen, you may find a cause. Just do resection, anastomosis, don't come out like that. Examine the entire GI tract. Lesions can be multiple. Is it clear? Otherwise, post-operative adhesions, as I have already told you, you can always wait 2, 3, 4 days because they are usually slow. This is very interesting. Of course, difficult to ask questions and get the answers. Look at this patient who was 50-year-old man. He came to casualty with abdominal pain, vomiting, distension. So there is obstruction. There was a bulge in the region of right iliac fossa. Can you see here? There is a bulge. This is the right side lumbar region, like this iliac crest here. This is the area. Iliac crest. When the question was asked, he said he had a fracture humerus, and 2 weeks back nailing and bone grafting has been done. So my assistant who saw this and told me, sir, there is a patient who has got this problem, and I palpated and I find some tenderness there. It's tender, and he told me it is mostly hematoma. Then he said, no sir, you come once and palpate. I examined the patient, and it is a little funny diagnosis, and I could examine and make this diagnosis based on one important thing, because I asked the patient to cough, because when I started palpating, there was a gurgle there, gurgling. So that means I knew there is some bowel has come there. And I asked him to cough, it was coming out, and he was having pain. I got the ultrasound done. It showed bowel loops, and CT showed, I will show the picture, Surgery was easy, reduced it. The whatever defect, I was able to close it and put a mesh. But I just want you to watch this carefully. Reconstructed image of the CT scan. This is the iliac crest. Look at that, so much bone was removed, little more than what was necessary. This is the cecum which has come there. And this will give you the correct picture. This is a rotation now. This is on the actually right side, this is left side. Look at that amount of the iliac bone which was removed, and that was causing the iliac, that crest graft site hernia. So this was the second case capsule. Now another patient, this is another patient who has come with no comorbidity. Look at the age, only 31. So no comorbidity means I don't suspect tuberculosis, etc. But he comes with a 1 week duration, and he said features of obstruction. And per abdomen there was a mass palpable. And I was a bit surprised because with the no features of tuberculosis, no fever, it's not common to get a mass. We did a CECT, showed a dilated loops. You can see here. And I opened this patient. You can see here, see, what is this? This is a membrane. This is a membrane. Can you see this? I took a lot of time for separation of this, and I sent it actually on the table itself, frozen section. They said no tuberculosis, because we know that in India we get tuberculosis. Matting over the loops is common. It may give problems. So then I search. This is called as abdominal cocoon. It is, tuberculosis is definitely one cause, but actually it is a original report was by, I have given a citation here, Fu is a British Journal Surgery article, and he postulated it's for retrograde menstruation. But nowadays it is not, this theory is not agreed. Nowadays it could be a low grade infection from the female genital tract through the fallopian tubes. So, and all these are various causes of abdominal cocoon, right? And the last case, again, all these patients will come suddenly in the middle of the night. Assistant said, one obese lady has come, sir, with a large swelling there, very tender, vomiting, and diabetic. He told, sir, mostly it is an abscess or a hematoma. He decided that I'm going to operate immediately. I somehow was not convinced such a large one. I thought there is something wrong. We investigated I told him wait, and we did a very important thing we did at this stage is that we got a ultrasound done. It showed bowel loops. At surgery, we opened that. This is Spigelian hernia. I think all of you know what is Spigelian hernia. Those of you who do not know, please read about it. This is the semilunar line, here comes there. Between the umbilicus and anterospinal spine, this is called as the Spigelian belt, also called as Spigelian zone. So this is also called as ventral hernia. Ventral means anterior. Incisional hernias also occur in the anterior, but because of surgery. So this is Spigelian hernia. Often they present with intestinal obstruction. So this is how it is. And obviously hernia principles are same. Open the sac, reduce the content. Gangrene means resection, no mesh. If there's no gangrene, if defect is broad, you use the mesh. So I conclude by telling that acute intestinal obstruction is a common emergency. One age group, different causes, another age group you will find different. You should be intelligent to find out probably what is the cause. History is important and a clinical examination. Never forget hernial orifices. I mentioned no fatty, especially fatty female, fertile, and all those means femoral hernia, small hernia at the femoral region. Do a rectal examination always. And remember, resuscitation forms the most important thing if you want to get a good results. Resection anastomosis, obviously if there's a gangrene or a stricture, etc. It's a commonly done surgery. Every resident should know. I have not given technical details. Normally it is a two-layered anastomosis done for a small intestine. I said when in late cases and risk, is some kind of a damage, advanced patient, bring the loop out, what has been called as exteriorization. There are so many causes we have listed out. So I am able to finish my talk at this stage. These are my various references, and I say thanks to all of you for listening to me very patiently now. And if you have got any comments or suggestions or anything for that matter, please email me or send feedback. So, sir, I am ready now for any take questions or answer or any discussion, comments, etc. I am stopping the share now.
Okay. Okay. Thank you very much indeed.
Thank you, sir.
Professor Raj, for this expertly given lecture on small bowel obstruction. It is full of information that even to me has been very useful, and I hope that all my younger colleagues will benefit from your talk, and I'm sure they will. And shall I mean, your conclusion have really summarized the whole thing, so I really don't have a lot of things to say except just to reiterate what you have mentioned about the importance of resuscitation, fluid resuscitation, and prevention of the occurrence of hypotension, renal failure, and septic shock. These people slip quickly into septic shock and die if they are not properly resuscitated. Yes, indeed.
Yes. Yes.
Yes, do you want to add anything?
No. If any one or two questions, because if you have time only, I will take.
Yes, you can have all the time if you like. I would like them to also to make sure that they make sure that their resuscitation is efficient. So it is not only required from them to write the instructions, but they have to come back and check their patients every 15 to 30 minutes, find out about the pain. Is it increasing, decreasing, or staying the same? Doing the examination, listening to the abdomen, do the rectal examination. Please, we hear people tend not to do it for some reason or another. I think it is very important. I think there was an old saying in one of the very old editions of Bailey and Love, that if you don't put your finger in it, you will have to put your foot in it. So this rectal examination is always, well, very frequently missed, unfortunately.
Yeah, the main reason in today's youngsters is that they will think that I am getting CT scan done, I am getting test done, so they will give a diagnosis. That is why I also mentioned that rectal examination and of course vaginal examination, looking for the hernia, femoral hernia, very important. You said a very important point. Thank you.
Thank you to you, actually.
Thank you.
Arterial blood gases, we don't usually in Sudan do because of lack of facilities, but as you mentioned, it is very, very important to do it. Please try to do it with whatever facility you have. The classical teaching once said that you don't do an ultrasound scan because of the gaseous distension and that the gas will not show you. But as you said, it is completely operator dependent. It is very useful. It can also be extremely useful, or the only thing you could have to diagnose vascular problems, vascular ischemia, whether particularly arterial ischemia, and you should always suspect it if you checked the pulse and you find atrial fibrillation in an elderly patient.
Yes.
Yes. The CT scan is very, very important, and our registrars, because they are itchy, their hands are itchy to...
Not only your registrar, I think the human mentality is same everywhere, but if there's investigation, it should be done immediately. Yes.
The only reason why I wouldn't do a CT scan is if it is not available.
Yeah, that is there. Yeah.
Yeah. If you are in a remote area where there is no CT
Correct.
scan or ultrasound scan, then you depend mainly on your clinical talent, which Professor Raj has shown you very well and described it to you very well in this session with all, you take a very good history, you take a very thorough examination. The more time you give to your patient, the more likely that you reach a diagnosis. Despite, our casualty are very hectic usually. Doctors are staying there for 24 hours, no proper food, no proper places to have some rest, and they are inundated by the flow of patients. But anyway, if you are a surgeon and you want to be a surgeon, this is a tough world you have to work in, unfortunately, even in the UK. And perhaps you have been there. You have seen how people work in very difficult situations. I'm quite pleased, and the information you've given us is quite rich, and I'm sure every aspect of this needs another session, really. But we will have to sort of hold ourselves a little bit and open the floor for discussion. And if anyone should have any query, please, the floor is open for you to ask.
Hi.
Hello.
Yeah,
Yes.
mine is a request. Is it possible we get this presentation?
Yeah, I'm not sure whether there was a recording of this.
Yes,
Yes, the session is recorded.
So it should be available.
No, I'm talking about the slides.
I don't mind. I just have to check how much is the. I will definitely send to the email whatever I have got. Okay, no problem.
Thank you. Thank you.
I will. My whole purpose is to share my knowledge. Okay, so sharing gives a lot of pleasure. So no problem. So but just go through the slides and make use of it. Thank you.
Thank you for a wonderful presentation.
Thank you.
Any other questions? I'm sure it will take a little bit longer for all this information to settle down in our minds and so on. But let me also stress something that you have said, which is that if... Yes?
Hello. Prof.
Go ahead.
Thank you very much for this presentation from this professor, which is very elegant presentation. I asked him, is he used any analgesia during intestinal obstruction, and which form of analgesia that he is used for his patient? Thank you.
What is the question?
Do you use anesthesia?
any type of anesthesia?
You're talking about analgesia?
Yes.
Painkillers.
Painkiller.
Painkiller.
These patients undergo surgery by general anesthesia followed by morphine
Oh.
and epidural. Okay.
Yes.
Okay.
Prof. Raj, I think I understand the background of this question.
Huh.
It has been generally taught that if you give an acute abdomen patient painkiller, you may mask the pain and you may make the diagnosis difficult. I think this is what he is talking about.
Just wanted to inform him that it is, I am telling, after surgery. After surgery.
You don't give before surgery any painkillers?
Before surgery, we definitely give painkillers, but usually we can prefer a non-sedative because, but today with the advent of investigation which are available, that old theory of that it will mask the symptoms is not taken that importance. Because today you have got various investigations to identify what is gangrene, what is counts are there. So many investigations. So that is the thing.
Yes. I think it is humanitarian. After you have seen your patient, at least, at least you would have made in your mind some differential diagnosis. And while waiting for the investigation, which could take all night in this country, I think it is humanitarian to give your patient some kind of analgesia. And as Professor Raj said, we don't give sedatives or non-steroidal. By the way, I am an anti-non-steroidal person because the patient is already in stress and will go into stress of fasting and will go into stress of anesthesia and stress of surgery and post-operative fasting. So I don't usually recommend non-steroidal anti-inflammatory. What is your opinion in that?
100% true, because always I tell my residents that abdominal cases are related to intestine. So they required more of a antispasmodics. NSAIDs are good for a muscular type of a pain, muscular type of a pain. And as you rightly put it, the most of these patients can develop stress gastritis, stress ulcers. So it is a acute gastric mucosal multiple ulcers and all. So I never give non-steroidal anti-inflammatory drugs in the post-operative period in abdominal cases. I try to avoid, in fact, for all the patients. Simple hyoscine bromide that you call as spasmoproxivin or etc. we generally give.
Right, sir. Thank you. Thank you very much.
Even a paracetamol at the little higher dose of 650 etc. will help.
That's excellent. Paracetamol is
Thank
available.
You,
Welcome, Professor Sulaiman Hassan.
Thank you, Dr. Mohammed Abbas.
Thank you very much. My name is Dr. Suleiman. I am a colorectal surgeon, one of the University Hospital in Khartoum here.
Thank you, sir.
Thank you very much for your invitation. I think, as Prof. Jamal said, it covered most of the aspects. But I've got just a general comment. In this part of the world, I think, as you rightly said, the commonest cause of small bowel obstruction is either an obstructed hernia or an adhesive band or adhesion. So these are almost, we cover almost 90% of the cause of small bowel obstruction. And I'm here to say that what I am telling our students, that small bowel obstruction is a clinical diagnosis. And all it needs, you listen to your patient, you take a proper history, and you do a proper examination. And most of the time, once you take a good history, proper examination, you should be able to diagnose a small bowel obstruction. Once you diagnose a small bowel obstruction, I think this question here, should I operate on this patient now, or should I wait and for conservative treatment. And I think this is very essential. So you have to know the cardinal feature of strangulated obstruction. And I think that one of the points which are very important is the character of the pain. And if somebody started with a colicky pain, that it start to wear out or to disappear, or to start with a dull aching pain, this is not a good sign. In particular, if it is associated with some tachycardia and so. So this patient will need an operation. It doesn't need a CT scan. If somebody presented with intense, tender, non-reducible hernia, this doesn't need a CT scan. This will need an operation. So whenever there is sign of strangulation, I think that the answer is surgery. It is not further investigations. And I think, I do believe, and I think the data supports this, that the role of CT scan in small bowel obstruction, I think is rather limited. You need a CT scan if you do a CT angiography, you suspect mesenteric vascular occlusion. Here the CT is mandatory. Or in if you are managing a patient with adhesive obstruction who had repeated surgery, and the patient is not responding to conservative treatment in 48 hours or so, he's not getting better, he's not getting worse. If he's getting worse, the answer is surgery. But the question that for those patients who are aesthetic, they are not getting better, getting worse, how long should I wait? Those patients, we need a CT scan in non-resolving adhesive obstruction, because you want to know whether is it a partial or is it a complete obstruction. If it is a complete obstruction, then here we need to have to operate irrespective of the extensive or the spread of the adhesions. But if it is a partial obstruction and the patient is not showing signs of strangulation and is not getting septic and is not getting tachycardic and so you can wait for some time till hoping that it will be, that this will settle on conservative treatment. Another indication I think is important for CT scan is in patients with metastatic disease. And it is very unfortunate to open a patient and close him and find wide spread metastasis all over. So I think the CT scan here will help to decide whom who will benefit from surgery and whom he will not benefit from surgery. Some patients you might decide from the start he is obstructed, but it's a very extensive disease. Multiple liver mets, multiple small bowel obstruction, and so on. This is not going to benefit from surgery. So he need, but for somebody for a localized obstructive tumor, or even with presence of secondary somewhere, he will benefit from surgery. So I think those are probably the indication for CT scan in small bowel obstruction. My worry is that there is a delay now, because almost all in this part of the world, the CT scan is not available everywhere. And sometimes our juniors, they wait to do a CT scan, and this would be a delaying investigation rather than helping the management. And what I am telling you, it is not necessarily to exactly know, especially if there is a virgin abdomen, there is no scar, there is no hernia, but the patient is obstructed. I think here you need an operation by a senior surgeon. It doesn't need to delay the patient for a couple of days waiting for a CT scan. So I think that the indication for CT scan, we have to be careful about it. Another pitfall of digital rectal examination, as Jamal said, in early small bowel obstruction, as you rightly said, that you may find that the digital examination, there is soft stool in the rectum. And this does not exclude obstruction because it's an early obstruction. I think the cardinal feature of small bowel obstruction are mandatory. That patient with colicky pain, with vomiting, severe colicky pain, with magnitude of distension, depending on the site of the obstruction. I think these are the cardinal features. And a loaded rectum or a soft stool in the rectum early on does not exclude obstruction to develop. I think you are waiting for a delayed diagnosis. I enjoyed your talk. Thank you very much.
Thank you.
Thank you very
Thank
much, Mr. Sulaiman. Mr. Sulaiman is a senior surgeon and a very expert person on gastrointestinal problems, and his comments really fits our practice here in Sudan, where most of the time you have to depend on your clinical talent, on clinical acumen to reach a diagnosis and start your management as soon as possible, because as he said, all the facilities is either absent, unavailable, or very delayed, and we don't really want to delay our patient waiting for a CT scan. If the diagnosis
Definitely. It is not mandatory. It is not mandatory. It is only a, if you have the facility, it may give additional information, but you can always proceed, because
Yeah.
the golden time is important. Let us not waste our time in asking for a CT. Yes. Thank you.
Thank you. Any other comments? I can see that.
I think Professor Jamal, for the sake of time, we can
Yes.
close the session and we welcome the next speaker from India
Yes.
also, and
I know.
welcome Mr. Omar Al Farouk. He will be the moderator of the next session, sir.
Okay.
Thank you, everyone. Namaste.
Thank you very much, Professor Raj. Thank you very much. We enjoyed it thoroughly.
Thank you.
Goodbye.
Thank you very much, Prof.